This week on the Backtable Podcast.
Anything else? So we mentioned liver, native, native kidney. Do you use it for targeted?
Yeah. Especially in large tumors like sarcomas, where you need a ton of tissue because they're going to do cytogenetics and all kinds of other fancy stuff on it, and they're still going to tell you, oh, that sample was non-diagnostic, despite the fact that you got 12 cores. And so in those cases, we're using the biopins a lot as well.
Hey guys, this is Chris Beck with the Backtable Podcast. We're here today at SAR in Austin, and I'm here today with Thor Johnson. Before we get started, just a word from our sponsor. Argonne Medical is the manufacturer of Biopins full core biopsy instrument. Biopins is the only clinical proven full core biopsy device that provides diagnostic quality specimens while reducing the risk of crust artifact and tissue fragmentation. With that being said, my name is Chris Beck. I'm an interventional radiologist and work primarily out of New Orleans in private practice. I'm here today with Thor Johnson. Thor, I'll let you introduce yourself.
Yeah, I'm an academic interventional radiologist. I work at the Medical University of South Carolina, primarily in interventional oncology.
Nice. Okay. So we're here today to talk about the Biopins biopsy needle. It's a biopsy device that maybe some of you guys may be familiar with, some of you guys may not be. And so let's just get right into it. Thor, do you want to talk about a little bit about the biopsy device and how it fits into your practice?
Yeah, so we decided to give this biopsy device a try just because we like the idea of the full core thickness. Plus, a limiting factor in liver biopsies in general, which is something that's of interest to us, is how much fragmentation you get of the sample. And so the ability to extrude a single solid core actually we thought might be helpful. And so we actually decided to prospectively sort of look at the biopins, and we compared it to our standard 18 gauge side cutting needle, 16 gauge side cutting needle that the hepatologists use, and then the transjugular 18 gauge set, just to see how good the samples would be, because there's really no cross comparison available of devices, and there's so many devices. It seemed like a good idea to sort of figure that out.
And what was kind of what did you guys find out about it?
So the biopins actually gives excellent specimens relative to some of the other devices we use. As a general practice, because we had already figured this out, when we do transjugular liver biopsies or when we do like an 18 gauge core for liver biopsy sampling, we tended to take 4 samples just because you never got enough CPTs when complete portal triads, which is sort of the diagnostic criteria for adequacy. You never got adequate samples when you took less than 4 cores. And so we compared, 4 samples of those to 1 sample with the biopins, and then compared that to what our hepatologist colleagues get with the 16 gauge device.
So they're using a 16 gauge side cutting needle, and they were still okay.
Yes, that's pretty typical for hepatology practices around the country. I interact with the hepatologist a lot, and that's probably the most common device overall for doing percutaneous staging liver biopsies.
Okay, interesting. As far as like the Biopins device, we're really familiar with it in our practice, but for those of you or for those people out there who may not use it as much, will you talk a little bit about like how's the device set up? Is it a trocar system? Is it an adjustable throw?
Yeah, so it is an adjustable throw, and unlike a lot of the side cutting devices, you don't extend the tray and then close the device. You actually put the device in, and then when you hit the button, it actually throws forward and then cuts all in one motion. And so the benefit of that is you actually get a full thickness cut as opposed to just the half tray that you would get with the trocar. And you can also get variable lengths depending on how nervous you are about how far out it's jumping in front of you. Okay. We only use the 18 gauge. I understand they have a 16 gauge as well, but we've never used that just because never use a bigger needle than you have to, sure, is kind of my opinion. And we tend to use the guide with it almost every time. And the real benefit I find with the guide is you can get your guide in place, make sure you like it, scan up a little bit, scan down a little bit, and kind of figure out where your safest margin to throw that 3.3 centimeters is. And so we'll actually torque the guide a little bit in the direction that's safer, just to make sure that when the actual throw comes out, it doesn't hit anything we're not in the mood to hit.
And the guide is that what you're saying is like the 17 gauge?
Yeah.
Okay. Yeah. So you put the
17 gauge guide, make sure look around just to make sure we're not going to hit the portal vein or anything like that. And then, and actually you want to go away from the portal vein too if you're going to do adequate biopsies for liver because there tends to be a lack of complete portal triads surrounding the portal vein, and so you want to kind of go away from that. So if you see you're getting too close to a portal branch, you'd kind of torque the guide a little bit to favor your throw going in a different direction.
Okay, so is it fair to say like you target a little bit more towards the periphery, or you just target?
Yes.
Okay, yeah. And so adjustable lengths on the biopens, I think, are 1, 2, and 3 centimeters. And so you're doing all 3 centimeter throws for your non-targeted
for liver biopsies as well as for kidney biopsies, because we've actually started using the biopens a lot for that. Just because, again, we're getting samples that are totally adequate according to our pathologist with one throw, as opposed to doing 2 or 3 with an 18 gauge or using the 16 gauge that the nephrologists use.
Okay. Anything else? So we mentioned liver, native kidney. Do you use it for targeted?
Yeah, yeah. Especially in large tumors like sarcomas, where you need a ton of tissue because they're going to do cytogenetics and all kinds of other fancy stuff on it, and they're still going to tell you, oh, that sample was non-diagnostic, despite the fact that you got 12 cores. And so in those cases, we're using the biopens a lot as well.
In the liver, seeing a lot of bleeding, or any of those patients having to go for procedures or extended post-op stays?
So over the course of the last 5 years at the University of Colorado, we've had 3 significant bleeds from a liver biopsy, 1 in a live donor, 2 in native livers. 1 required treatment, like 3 of them got angios, only 1 of them actually had something to embolize. And none of those were actually biopens cases. So we've done probably 150 or so, and we haven't had any bleeding to this point.
Any with the kidneys?
Not with the kidney either, no. We're pretty wimpy about kidneys, though. Like, we are very particular. Kidney has to be more than 9 centimeters or we won't biopsy. Kidney, they have to have completely normal blood pressure or we won't biopsy. We're pretty careful, and then we're also pretty careful with gel foam pledgets, both for the liver as well as for the kidney. And what we'll actually do is cut up gel foam pledgets and kind of push them through with the trocar, the needle, just so that we're not pressurizing the track by doing, torpedoes or slurry or anything like that. So that's kind of been our approach, actually, with that. And anecdotally, we haven't analyzed that, but anecdotally, it seems to be helpful.
Okay, that's great. That's actually a pretty good tip. So let's talk about maybe some of the nuances of the biopens. There's a safety mechanism. How do you like the safety mechanism?
I don't like it at all.
All right. I think that is one of the gripes of the biopens is the actual safety mechanism, because sometimes it can be just a slight cumbersome to, like, if you get it and
push the side button and then try to readjust your hand so you can actually hit the back button. It can be very cumbersome, I think. And I don't know a circumstance in which I've found it all that useful.
Yeah, like when have you ever wanted the safety on in that situation? Yeah, so oftentimes the play is to actually take off, like I immediately adjust the throw, take the safety off, but every now and then when I lay the biopens back down.
Yeah, it like bumps the button and you end up hitting the button and nothing happening.
Yeah, exactly. And then you kind of have to slide your hand right and then hit the safety off again, which is not a big deal, but it just sometimes.
Nah, you get used to it. It's like any device. You figure out its sort of little picadillos. But yeah, I don't like that at all, actually.
How about the visibility of the device, like the needle tip under ultrasound? I guess you're talking partly because the guide and also the biopens itself.
I think they're actually quite visible. I think as long as you have, you're trying to be perpendicular to the plane of your imaging with your ultrasound, we don't have any issues with that. Although, to be fair, we're a very, very heavily ultrasound-guided practice, so that may just be our experience. But by and large, we have no trouble seeing the device at all.
Yeah. Actually, I can echo that sentiment, and I can't say I'm a little bit more prejudiced towards ultrasound. I think my partners who are a little bit further along prefer CT. But
old guys, is that what you're trying to say?
I was going to try and say old guys, and further along I thought was a more polite way. But
long in the tooth.
Yeah, but I don't. They never have any complaints about visualization either. I mean, I think with anything, sometimes there can be, you have an extremely long throw and a fatty liver, and those pose their own challenges, or a dome lesion. But overall, I think it's just as visible as anything else. All right, so any other, did we miss anything? Any other pros, cons to the devices that it didn't bring up?
The only other con is that you do have to be careful if it's a very fibrotic lesion, because you can bounce off. We've seen that before, where we're trying to biopsy a lesion with the biopins. You stop short, you hit the throw, and it hits the outside of the lesion and kind of skitters around it. So that has happened to us a couple of times, usually with very small fibrotic lesions in a cirrhotic liver.
So is the play there to take your guide or your 17 gauge needle and advance it in?
Capsule.
Okay, so I think that's a good tip, is that whenever you're doing it, enter the lesion if you have the room for the throw, so that then you can throw through.
Especially if you're concerned that it's fibrotic. You can usually feel, that's the other thing I like about using the guide, is you can actually sort of feel how fibrotic it is with the back of the guide. And so if it is like that, then it is something that we think about in terms of using the device.
Okay, excellent. All right, well, guys, like I said, we're here at the SIR Austin at the exhibition hall. I think this is going to wrap it up. We just wanted a quick, good podcast to talk about the BioPins device. If you want, you can find more information on the BioPins at argonmedical.com/BioPins. Be on the lookout for exciting news from Argon Medical on their full core biopsy products and the range of which you can find on their website. And guys, as always, if you want to connect with us, feel free to tweet us. And our Twitter handle is @_backtable. We always want to hear what you guys are talking about and what you like, what you don't like about the podcast. This is Chris Beck with Backtable, and I'm with Thor Johnson. Thanks for coming in today.
Thank you.